This is Optometrists Building Empires, and I'm your host, Ankit Patel. Each week, we'll explore the journey of multi-practice ownership and leadership in optometry. Join us for insights and strategies from the top minds in our field. This show is sponsored by My Business Care Team. My Business Care Team helps your office increase revenues, reduce costs, and reduce staffing headaches. Let's build your empire together. Today's guest is going to be a little bit of a unique take. She's a distinguished optometrist with a deep-rooted passion for patient care, education, and innovation in the field of eye health. She's a dedicated educator, researcher, and speaker, sharing her expertise through lectures, editorial contributions, and her involvement with professional organizations. She now practices at the University of Colorado School and specializes in anterior segment and ocular surface diseases, neuro-optometry, and peri-operative care. She also hosts the ModPod podcast, which is a podcast about modern optometry. She's optometrist, speaker, and assistant professor at University of Colorado. Please welcome Dr. Cecelia Koetting. Cecelia, welcome.
Hi, thank you so much for having me.
Yeah, I'm excited. This is going to be a little bit different conversation. Normally, we have folks who, talk a lot about their practices. You're coming at it from a different angle. And so this podcast is about how do you create your quote unquote empire in optometry. And so you have a really unique perspective on this. And I wanted to give you some space to talk about your specialty and your niche and why it's important for folks in optometry who want to grow their business, either make it an empire or just have a good business and a good practice. So I want to start with that is it's a little bit more about you and what is your mission growing empires?
So, somehow I have really found myself in a spot of ocular surface disease in cornea. I still do neuro, but I really would say there's actually a huge overlap between neuro and ocular surface disease, especially when we start talking about neurotrophic keratitis and things like that. But it is an area that is growing. It is robust. It is no end of patients. So there's always more growth that can happen there. And it really stemmed, I originally started working in Virginia we're almost 12 years ago at this point. I had an MD-OD practice that was specialty tertiary care, surgical co-management. And, at that point, they had me as an extender for many different things. And since I've left there, I was doing ocular surface disease and cornea, but it's really kind of honed into that. And while I'm at a university now, I still think that, and which is why I'm hoping to maybe impart this on your audience, is that this is someplace that or something you can grow any place, right? Whether that be a private practice, whether this be something that is you're in an MD-OD, you're in a university, you're in a brick and mortar, maybe a Walmart or a Target. I think it's something that if you want to start small, you can start small, but you can kind of do this anywhere.
Yeah. And I think when we were talking a little bit about before the podcast, you were saying that niche, right? It is important and you've kind of got a knack for that.
I do. I mean,
tell us about that.
For better or worse, for if I love it or not, I actually do very well in this space as far as making the ability to take care of these patients and solving a problem, because they come to me frustrated. They seek me out or referred over by it's in this university setting. I get a lot of referrals from oncology, from my fellow colleagues, my glaucoma specialists who induce a lot of ocular surface disease. But these patients come, sometimes I'm Dr. 4 or 5, and they've been told, oh, there's nothing I can do, or, here's some artificial tears. And there's just so much more that we can do for these patients. And honestly, I'm not that special. We can all definitely do this.
Yeah. And a reason I really like having you, wanted you on the podcast too, was so many times we've talked to several guests and almost every one of them to a T is, hey, you have to have some sort of specialization.
Mhm.
And so I wanted to see like, hey, this is something that's unique that I think that's from outsiders' perspective looking in, it's something that doctors could probably implement fairly quickly and they could get comfortable
Yes.
fairly quickly with. And there's not many people doing this at the moment, at least. I don't think, at least that's my impression that I get. So
It's
yeah,
about 10%,
yeah,
of people who are really specializing in it, and honestly, when I made the switch over to the university, I had to take a really quick hard look because I needed, we can't being without a job for a long time is not easy. So I had to make a decision. And one of the thoughts I had, and it still percolates, it's still there, is actually striking out and just doing an aesthetics ocular surface disease clinic on its own. And there are some of our colleagues that are doing that, but there is, from multiple standpoints, right? There's money, there's absolutely money that can be made there. I mean, I watch even at the university, I'm able to see what
yeah,
I'm bringing in, how, how it's growing and how my clinic is growing. From a standpoint of patients that need help, there is a demand. They're looking for it. They're frustrated. They need help. They're looking for people who are in this. And then also from the aspect of gratification for what we're doing, right? Why didn't any of us become a doctor? Let's be honest, it's probably not just the money. It's we did this probably more altruistically, and being a optometrist typically are pretty empathetic. So there is a lot to be gained personally from the gratification of being able to really help these people and make a huge difference in their quality of life, and just overall functionality.
yeah. And so let's back up one step. I'm kind of curious if you're talking to an optometry practice owner. They wanna specialize in a niche. They don't know what they wanna specialize in, right? And let's just say they
Yep.
have just the standard, no residency, anything like that. They're standard out of school, maybe like 5, 10 years, been practicing, mostly traditional, practice. They may see 20% or less medicals because they're Medicaid patients or Medicare patients. Standard practice, like you come no particular niche. How do you go about like finding a niche? How do you think about that? What type of niches have you seen work well? Kind of talk me through that process a little bit.
Yeah, so I think there's a couple things you have to look at here, right? If you have, a small practice or a practice whatever size, right? And you're really looking to say, "Hey, I want to." That's the first part, right? Do you want to go into niche? Do you want to just continue to provide, good care for your patients and doing what you're doing? Do you want to hone in on something else a little bit more or lean into something a little bit different? You're gonna know your practice the best, and you have to look at what your patient demographic is, as well as what's your comfortability with pushing your boundaries. I think pushing boundaries is really important. That's kind of what I tend to do is I lean into what's uncomfortable, to feel more comfortable with it.
And let's talk specifics, not generalities. What am I looking for in my market? Like, how do I know if I'm better at dry eye practice versus yeah,
Absolutely. So you're looking at, what are your patients? Can you develop a niche, right? With dry eye, it is probably the easiest one, right? The lowest bar. Do you have a slit lamp? Do you have dyes? Not even dyes. Do you have fluorescein, right? And if you start putting fluorescein in every patient and listening to all your patients, implement a questionnaire. Cheap, easy, right?
is that yeah,
Free to print off, have your patients. Start looking at it and going, oh, okay, I have patients who have symptoms. I have 20%, 40%, 50%, right? What's your percentage of patients that have symptoms? And then couple that with what are you seeing as far as ocular staining? Because we know that there's not always, there's going to be patients who don't complain about things because it's
yeah,
become their norm. And when you can start identifying that you have these patients, you can start to feel more comfortable with then pushing the next steps
do
in
the
this,
next
right?
step.
Yeah. Yeah, I was gonna say just and once you can identify that you have the patient base, you can say, "Okay, what's my next step as far as do I want to bring in more testing?" But I think even just starting to get comfortable with treating these patients is really the best thing.
So what I'm hearing is dip your toe in the water. Don't go spend a $500,000 on IPLs and all these other dry eye
No.
treatment. So start off simple with, does your patient base, how much of your patient base are you seeing? So if you see 5,000 patients a year versus 300 patients, those are very different scenarios. So your
Correct.
percentages, you want to look at the raw number too. Does
Yeah.
the raw number justify it? So let's say you come in, you implement maybe try for 2 weeks, you implement a speed score of fluorescein drops on everyone, and
Yep.
you look for certain things that you would maybe say, hey, this person may need ocular surface exam. And
Hmm.
I'm going to bring them back for an ocular surface exam where we treat the ocular surface issues I see based off of conditions on the speed score and the fluorescein drops. Is that something like an approach you would take?
Yeah, it would, especially for a lot of us that are taking both medical and vision insurance. I think that's a great way to approach it
Mm.
because it does get into a sticky situation of, hey, you're here for X, Y. Yep. And then you're switching it and patients don't love that. We know.
No.
Nope. So I say that that's a great way to do it, but it also gives you more time.
Mm.
You don't have enough time in your annual exam or your regular exam to walk through the 15,000 different things that we have to and talk to them about glasses and talk to them about dry eye, right? And then what are you going to do about it? They're going to get overwhelmed. You're going to be overwhelmed. It's not going to work out very well. So it's not setting yourself up for success. So have them come back for a dedicated exam, right? My life is a little different because all my exams are dedicated at this
Yeah.
point. But what I used to do was you're coming back for a dedicated exam. I'm going to take a little bit more time. I'm going to make sure, to not only reassess with the vital dyes, I'm also going to make sure I'm looking at the lids, I'm pushing and pulling and looking at all of the quality of the meibomian glands, right?
Maybe you do like a cheer film breakup test or something like that in addition to
Exactly. Yeah,
that.
exactly. So if the other thing to remember is if you don't have I think the low hanging fruit for things to bring in next step, if you really want to start building it, probably a mybographer. There are a number of different ones that are out there that have multiple things that you can, other tests that are with it. So as you grow, you can feel more comfortable and you utilize those. But if you don't, before even that, you have a transilluminator. You can look at the meibomian glands. It's really hard to image them and show the patient, right? But you can at least assess the meibomian glands and say, okay, I've pushed on them. Here's the quality. What is it coming out like? Is it hard to come out? Is it coming out easily like it should when we blink? Is it coming out like toothpaste or is it looking more cloudy or does it look like olive oil and it's perfect? When you do those things, those are conversation points that you can have with the patient to give them information as to what you're doing, why you're doing it, but it also helps you build up your confidence in what you're doing. So then you're able to kind of, watch that, monitor it, and then come back and say, hey, look, that did get better. I am going in the right direction. I mean, I didn't get to the point where I am right now, feeling confident in what I'm doing. Walt Whitley will tell you I was the worst salesman ever. I did like 0 lipoflows for probably the first 5 years I was at the practice. And then all of a sudden, I started feeling more confident with all the testing I was doing and my patients coming back to where I was like, ooh, okay. I see the pattern. I know how this works, right? And I
Yeah.
know what I need to do now.
And that's a great insight. So it's not just about, does this make business sense? Let's say, so let's back up a step. If you can't put numbers to it, I would love to hear like your estimates. So if I start doing the speed test, the fluorescein drops, as well as maybe even checking out the light and just checking out the health of the meibomian glands.
Yeah.
Let's just say I do that add in maybe a couple extra seconds or minutes in the exam to do that. I present it to the patient. What kind of conversion should I look for? Like, am I looking for like 20% or 30% of patients that are willing to come back for an exam? Is that what you like? Is there a particular number that you look for that's good or anything? If you don't have a number, that's okay. I know it can depend, but
Yeah, and it can depend, but I would say probably look at about, again, depending on demographic, right? You're probably looking somewhere between 20 to 40%.
of presenting conditions or people willing to book an appointment, because I think those are two different things.
They are two different things. So presenting, I'd say you're probably looking at probably 60%, right?
60%.
Let's
Okay.
be realistic. It's probably 60% because I technically would say everybody has ocular
Yeah.
surface disease until proven otherwise, right? And some level of meibomian gland problems, right? Probably looking at 60%. I'd say of that, depending on how you're presenting it, you're probably looking at 20 to conservative, right? 20 to 40%, because you're talking about all these people who are coming in. If you're looking at our regular old practice that doesn't currently have a niche, right? You're probably looking 20, 40%,
Got
I
it.
would say conservatively.
And from a practice management standpoint, you tell me what you think about this approach because I'd love to hear your insights.
Yeah.
My first step would be let me do these tests, new extra tests. If I don't see over the course of a month or 2 weeks or however long I want to do it to make sure I get enough samples, if I don't see at least 60% of the people that would qualify for an exam, that probably tells me I may not be ready for it. Let's say I do see 60, 80%, everyone had issues presenting in some way or fashion that I would say, yeah, if I'm the doctor, which I am not, by the way, but if I was a doctor, I'd be like, okay, yeah, I would say this person needs to come back for ocular surface exam.
Mhm.
Then the next step would be let's start booking them for that exam. And I should ideally minimum try to get to 20% of those people into the chair. So if I have 100 patients, 60 of them present. So we're looking at basically 20% of 60. So that's about 2 or 3 exams that you should see. Is that number right? Or are we thinking
Uh,
20 out of 100?
20% out of 60 would be
12,
12.
12. Sorry, I can't do math fast.
Okay.
Yeah. So you should looking for about 12 exams at the bare minimum, and people, and then out of that, and certain show rate and things like that. But to make the math work, you probably need to hit those ratios. And if you're not hitting those ratios, then it's a question of what are we doing to get there. So
Right.
maybe fixing that part of it before you take the next step.
Yeah.
So maybe it's a doctor confidence issue. Maybe they're not coming back because the doctor doesn't feel confident with it, and that we can work on that. Maybe it's the messaging or how we're presenting the challenge. We can work on that. But if we have 60+% of our patients presenting with any kind of challenge that the doctor would deem necessary for ocular surface, and we're not getting 20% of them coming back for ocular surface, we should be fixing that first before we
Correct.
go to the next step. But
Correct.
it doesn't mean it's dead. It just
No.
means that we have work to do in our
Approach.
process internally.
All about approach. All about approach, 100%. Mine has changed, like I said, significantly over the years. As I understand more, I'm able to better have a conversation with my patients and get them to buy in because I know I'm confident in what I'm doing and I'm confident in what's going to happen. So that's the thing is like, yeah, I say 20% conservatively, but as you build and as you build a name for yourself and people are specifically coming for that, or you're getting, colleagues in the area, other optometrists doing lateral referrals because guess what? They don't have it or want to deal with a dry eye, right? And they're like, you like it, you're good at it.
No.
Here's the patients, right? So you build that. Now, that's why I say 20% is really conservative, but it's very easy to grow that to be quite a bit more.
Mm. That's good to know. What are some like really excellent practices that do this? What are their top end like ocular surface exam rates?
So I'm trying to think. So I know for me, again, because
Yeah.
I'm 100% ocular surface disease. So
Yep.
there you go,
Hey,
100%.
your entire
Um,
schedule is full of ocular surfaces. Yeah. That's
yeah.
amazing.
So two people that I would say are great to look at, who've done a really phenomenal job, not only with building their practice, but also building it to the point where they now have a separate business for aesthetics and ocular
Mhm.
surface disease. Carly Rose,
Mhm.
who has done a great job, and she's also phenomenal at marketing. And then also Janelle Davison down in Atlanta. She
Wow, yeah.
finally, yeah. So both of them, oh my goodness, they are great business leaders. They're great doctors, but they just like they see that next level, right? And so they've gotten to the point where they started small, both of them, right? They started small in their original office, but then as they grew those patients, and that patient base and the referral base, they were able to go and open a second location that is dedicated solely
Just solely for
to
that.
try. Yeah. Yeah. So
So they're
percentages
doing
I might not
something.
have, but I can definitely tell you that there are examples of how you can grow this.
Yeah, and Dr. Rose is located in Cincinnati. Is that right?
Yes, yeah.
Okay, yeah. That's fine. So if anybody wants to look them up, I think that gives you an idea of the top end of what we're looking at for this, and you have a good product market fit. And so let's talk a little bit about maybe some other niches that might be that you like or have done? Are there other niches that doctors don't necessarily think about that are like, okay, this is actually a good opportunity that I see?
Yeah, I think there's a couple. One, I think this is probably more obvious, but sclerals.
Hmm,
Um, they do couple with ocular surface disease, but guess what? I don't do them. I don't do anything with contacts or glasses.
interesting.
Anybody who knows me probably knows that. Um, but I am a huge proponent of sclerals for my ocular surface. Do you have to do both? You can if you want, or you can specialize in one. And then guess what? People like
Leave the
me,
other one.
I lateral refer, right?
You're
So that's a huge opportunity that's right there. I think that there's more and more people who are doing that, which is great. They are taking that. A couple of things that I see as areas where we can expand that people aren't so much in right now is myopia management. Yep, especially with new treatments that are being FDA approved and moving over. We understand it's an issue right now. So that's definitely an area with scope expansion in states, right? Certain states. I think that another niche can be medical optometry only, in such that treating things like SLTs, doing YAG lasers for post cataract, and then depending on the state, possibly doing PRK LASIK corneal cross linking, right? So medical in general is a big niche that if you're like me and you're not a you know not huge lover of contacts or glasses, and you wanna go that direction. I think there's a lot to be said for developing that. Um, third or another one, that I think we're gonna see more of as well is actually optometry, and again, this is gonna depend on state and the laws, but optometry-owned office-based, surgical centers
Mhm.
that are they're essentially minor procedure rooms, but by that, I mean, you may own it, you're not doing anything with it, but you're owning it and bringing in, ophthalmology to use the space to do cataract surgeries, etcetera. And so I think that one's gonna be that I think that could be a really big opportunity for the right person and in the right state.
Yeah, actually, I think we had a guest. I think the video just dropped, not that long ago, Blackburn in
Okay,
Indiana.
yeah,
They're similar to that. They have it's a little bit of a hybrid. Ophthalmologist started in, now an optometrist slash ophthalmologist own it. It's
yeah,
interesting, uh, I see it going that way.
yeah.
So let's talk a little bit about those folks who are glasses and contacts heavy. What I heard there was, yes, dry eye, it's all the rage. A lot of people are trying to do it, and there's a good path to it. Let's talk about just another stepwise function. If they want to step out, it sounds like scleral is a good opportunity
Mhm.
if they don't feel comfortable going all the way to the dry eye. So let's, like we talked about with, like, how do you step into that? How do you step into scleral if you're doing traditional contacts and glasses, but you want to maybe look at more specializing in contact lenses like sclerals? What are the things that you look for there?
So I think, anything, any of these in general, if you're interested or you're thinking about it, obviously you do a little soft test in clinic to kind of think about things. Talk to your colleagues in the area, look at who's maybe already doing these things, especially with sclerals. And, you know, hey, how many patients are you seeing? Are you finding that you don't have enough time? Are you getting referrals? Who are you getting referrals from? A lot of us are willing to have these conversations with each other because most of the time the market's bigger than we can actually handle on our own. Um, within clinic, I don't know. The big thing would be looking at your existing patients and who do you have patients that are severe ocular surface disease, post corneal refractive surgery, anybody who you've traditionally had a lot of difficulty with getting into a good vision range with
Mm,
glasses or contact lenses, traditional soft contact lenses, or people who drop out because they're uncomfortable. That's also a really good place to look as far as for dry eye too, right?
mm,
So patients that drop out of contact lenses because they're uncomfortable, it's probably not the contact, it's probably ocular surface disease, which affects bottom line for you, right, as a clinic owner. Um, so those would be the places for scleral or even dry eye that I would be looking at as potential patients as well.
and sclera is one of those that I don't believe, I have to double check this, but tell me, you don't really need a lot of special equipment for that, correct?
if you have a topographer, it's great. If you
Nice.
have anything for ocular, but it doesn't mean you have to start there, right? And, again, I'm not doing it, but I have an okay understanding, right? In the, you know, I think anytime you're looking at moving into a direction, education. Talk to your friends, go to something, go to a weekend long course that's really heavy in it so that you can maybe understand some of the basics and what does it really entail so that you can figure out how to start this if it's something that you're interested in.
Yeah, and I'll add in, AI is usually a good place to start too, just
Or
in terms of just thinking of ideas you may not have thought of and
yes.
questions to ask, because sometimes we don't even know what we don't know. I wouldn't use it for the complete plan,
No.
but, I would say that it's not a bad place just to say, "Well, hey, if I wanted what would be the steps I would take if I wanted to test this?"
Yeah,
And then
absolutely.
ask your colleagues and friends like, "Hey, what do you think about this? Is this how you did it?" If you wanna come prepared a little bit, that's a good place to start.
Yeah, absolutely. I would agree.
Excellent. So I think one of the things that folks are facing in terms of, and I don't know how much you see of this at the university, but challenges with reimbursements, challenges with staffing. Are you guys experiencing that at all?
I don't know that anybody doesn't deal with that. Um, yeah, so we know with reimbursement, it continues to drop. I'm probably a little bit more shielded. I do all of my own coding and billing, right? But as far as shielding from feeling the effects of the decrease in reimbursement, currently not so much. They do push to try to obviously increase volume if we are decreasing in reimbursement. Um, but it is a concern. I talk with my colleagues about this, right? It is unfortunately pushing us to need to do more or think about how to do things smart, right? Work smarter, not harder. I think AI is going to be a big part of this, and that's why I'm not necessarily a proponent, but I understand that when it's done correctly, it's actually going to help us. There's a number of things being developed for in clinic, as far as things like AI scribes, as and triage, which means that helps two burdens, right? Both the burden of us and decreased reimbursement and having to maximize time and profit, but also with staff. Um, Not only helping to decrease maybe the amount of people that we need, which most of us I think are probably understaffed at this point. I don't really know anybody who's not struggling with that, or continuous turnover. It's better than it was in 2020 to 2022. I think that was a really hard
Yes.
time. But AI can, one, help take some of these burdens from that staff that's already there to decrease what they're having to do, but also help with the flow of clinic. So I think
Gotcha.
as we have new options coming through, it's going to be helpful.
Okay. Yeah, I think it'll be interesting to see where that
Yeah.
goes. I mean, full transparent disclosure, we started my business care team because of this. We had those staffing challenges,
Yeah.
and I was like, okay, it's tough.
Yeah.
Uh, and so I want to circle back to something you said earlier, that I don't want to lose sight of. I think a lot of doctors listening might have this question. It took you 5 years to go on that journey for buying into this ocular service. What were those triggers? And if I was a doctor who had associates who I could buy in, how do I get them to buy in? And how can I help them buy in to ocular surface, myopia control, anything I'm doing? What
Yeah.
was your journey that was the aha moment? And how can we translate that and ball that up for other doctors for specific ocular surface?
Yeah. So I think there's, that journey started with recognizing, yes, there's a problem. Okay. And it wasn't that I didn't, it was the what do I do? Right. It's like, do I want to identify it if I don't know how to deal with it? Right. I think that's where a lot of us start is okay, now I've got the problem. What do I do with it? Um, and regardless if that's myopia, you know, any of these things. Once we start to recognize and starting with that, just the speed questionnaire, the staining. looking for those clues, you start to go, okay, let's think about what am I seeing? What is likely the underlying cause? And what is the most appropriate treatment for that? And understanding that it is very rarely going to be one thing, it's usually multiple. And that can be overwhelming. And with ocular surface disease, it's usually multiple things at the same time, and that's okay. Um, so I think getting people to buy in is conversations. If you are bringing in an associate or you have a new grad, remember that yes, they learn lots of things, but remember that they've been trying to focus on one thing, which is graduating and um, passing boards. And boards are about 10 years behind from clinical practice. So they still need help. They're still going to need direction. Have conversations. Be a mentor. Take a moment, have a conversation like we're doing right now. I am very open about having conversations with anybody who ever has a question. I'm like, yeah, let's go get coffee. Let's go have a cocktail, whatever. Let's talk through things. What are your questions? Send me photos. I don't care because we need to rely on those who maybe have already figured out that way to help give us some direction. Now, if you are you and you don't, you haven't figured things out yet, don't be afraid to trial and error. It is okay. Yes, you may have a few patients who at the beginning are like, "Do you know what you're doing?" And you're like, "Yeah, I totally know what I'm doing." Right? And you're in the mind, you're going, "I am trying to figure this out." Um, be thoughtful about what you're doing, but be okay with pivoting.
Mm-hmm.
And the other thing that gets thrown in here is, let's be honest, insurance, we love it, we hate it.
Mm-hmm.
It dictates how to be a doctor. And it is ridiculous. Um, use your reps. Your reps are your friends, and they are there not only to give you samples and lunch, right? Samples are great. Lunch is also lovely, but they're good resources for how do I get this drug to my patient? What are the best things in our area with insurances to work around the denials? What cash pay programs exist? What coupons exist? What's the best pharmacy to send these things to? And that can help decrease not only your frustration, the patient's frustration, but also the burden on your staff.
Yeah.
And also don't forget there's usually a field access team which can help your staff, like teach your staff how to go through prior authorizations or what's the best way to approach these things so that it makes it quicker and you're getting the things that you want.
Yeah, and from ocular service standpoint, I think that's a lot of really popular one because most of that's kept in house, and you don't have to worry as much about pharmacies. The majority of treatment plans usually can be kept in house with ocular surface and dry, at least dry eye.
Yeah.
And so I think that's why it's such an attractive one. But what I'm hearing is, let's say you want to get, we talked about how to get started if you haven't started yet. But if you wanted to enhance your associate doctors that you have, sounds like give them a clear path of understanding and show them the why. And like, this is what happened. And maybe even mock, like role play a little bit.
Yeah.
One thing that we do is our chart reviews once a week with doctors
Ooh, I
and
like
going
that.
over,
Yeah.
oh, this could have been something that we could have done. My wife, who's a doctor, says, oh, this is how I would approach the situation with this patient because they had these things presenting. And they're like, oh, interesting. Okay. And that helps build confidence along with having enough visuals in the office and giving them, here's a plan, a protocol. You don't have to use it every time, but there's some guideposts that help you kind of think through.
Yeah.
It shows up as this is what it looks like. And honestly, many of the associates that have worked with us and will work with us now, they like the fact that there's a team of folks they can rely on. The doctors seem to like that, especially if they're relatively new out of school. Like, oh, I have someone I can go to and learn and expand.
Yeah.
And I think that's also important. I think we that social support side of it tends to be left out sometimes. Like you said, talking to a rep or talking to another doctor in the office might be helpful.
Yeah.
So it almost sounds like if you're the owner and you want associates to get better at dry eye or myopia control, it's developing that clear path and giving them the confidence. It's more work in between the years versus the technical pieces and more just feeling good about it. It's like, oh, I don't. I would also add is having a good enough relationship with them so that they feel comfortable saying they don't feel comfortable
Yeah.
with things. I think that's a big one too, from a management perspective. Is like, you gotta have to read, are they really comfortable doing this? And if they are, they say they are, but they're not, why are they telling me something that's off?
Right.
There might be some other stuff you have to handle first before you can go down this path.
Yeah. No, absolutely. I think that another uh, underutilized thing is don't forget to take them in the room. Have them
Absolutely.
listen to how you approach this. What's the conversation? Honing in and developing the way that we approach stuff, it takes years.
Yeah.
It's not developed overnight. And allowing them to listen in is actually really helpful. And a lot of how I picked up how I have conversations about things with patients. And, I've changed it over the years to what works for me, but it was a really good way to just be like, oh, mm, that's a great way to discuss that. And I'm looking at this patient and watching them go, oh, right, buy-in, right, from the patient. So it is great to be able to do that and just make sure that they're able to grow. You want to foster, like we're both saying, absolutely.
Yeah. I think, at least I know I'm guilty of this sometimes. It's like, hey, I told you to do this, just do it. It's like almost like you're a machine, right? And people aren't machines, and that can be tough sometimes.
Yeah.
Um, so let's switch gears a little bit. I'm curious to see kind of what makes you tick. Uh, what can you share with me and share with the audience an experience in your life that was really formative that you felt made you who you are and kind of brought you to where you are today? So it could have been something like, hey, it was back when I was a little kid or a teenager or college or maybe 10 years ago or more recent, but something that was so impactful for you that you're like, yeah, that is one thing that helped me make me who I am today.
I think there's a couple, and I do want to share both.
Okay.
So for sure, just I had a really strong role model as a mom. Both my parents are great, but I definitely had a very strong role model of my mom who told me to question things. And it was probably great and bad at the same time because she's telling this, 12-year-old, are you sure your teacher's correct? You should verify. And if you don't think that your grade is correct, you can ask. You can challenge. And so that has always put a drive in me to not be confrontational, but to think about things and to be intentional in what I'm doing and to make sure that I have the facts and that I'm backing that up and that I am okay with saying I don't agree with something or in a situation of, social, I don't agree with how this is being done.
Mm,
So absolutely that is one of the big formative things. The second one, I will absolutely tell you, I feel like a much better doctor since 2020. And 2020 was not fun for all of us, right? But on top of that, I actually had colorectal cancer.
oh, wow.
And so for me, I had to go through this journey of stage 3, everything, going through health issues. And I think that it made me slow down, for one, but also to become a much more empathetic. I've always been empathetic, but I really feel like I'm much more, and I also put a lot of myself out to my patients, because they're going through health issues. They're, even if it's like, "Oh, it's just dry eye." It's not. It is awful. It's not fun. These patients are really miserable, and all they want is someone to listen, and they want someone to help. And so I think that I've definitely become a better doctor because of it, because I just am better able to empathize and sympathize and have these discussions with my patients. So I think it is one thing for all of our colleagues, to remember, is that putting a little bit of yourself out there to the patients and being human is really helpful, for both sides, because it gives yourself a little bit of grace, right? But it also makes the patient, feel like maybe you're a little bit more involved and invested in them.
Yeah. And you hit on something really interesting because you're right. Some people is really serious. Like if you have Sjogren's, man, it is awful. And they're hard responders, and
Yeah.
there's a certain percentage of people that even if you go through all the standard treatments, they still don't respond. And what do you do? And how do you do that? And I feel like we could come up with a whole nother podcast just around that on the
Yeah.
technical side. But I think that's kind of what your podcast gets into, Mod Pod. Modern optometry, is that a little bit? Yeah.
So sometimes, yeah,
Yeah.
usually it's based off of whatever, the articles in the current periodical modern optometry. I'll go through and pick a few of the authors, the guest authors from that month. I'll bring them on the show and we'll kind of walk through things and have conversations based off of that. Yeah.
Yeah, I think, thank you for sharing your story.
Of course.
That was a hard time to go through cancer as well because of the fear of COVID. We didn't know, and like,
Oh,
hey,
yeah. No,
yeah,
nobody could visit.
well,
Everybody, we were all treating each other like we had the plague because, there was that. So it was a lot of distancing. The support system wasn't there that normally is. I still had a phenomenal support system with my clinic. Everybody put me on a meal train. They were all dropping food off at my door, and then waving at me from the street. And then of course I had my husband who was there, he was my rock. So
that's awesome.
we
Well,
made it through.
I'm glad you're better now.
Yeah, me too.
And, and as far as, and let's say now you've had a lot of rich life experience since you've graduated, but if you had to go back, knowing what you know now, graduated, it's a week after graduation of OD school, what would you tell your younger self, knowing what you know now?
Hmm. That's a great question. I would say one, you will pay off your student loans. It will be okay. And two, embrace the uncomfortable. And I always have, right? But just a reminder to myself that embracing the uncomfortable, whether, that be that, I did residency, I got my first job. My first job did not pan out. Moving forward to the next. And I think that reminding myself that is the path that works the best for me is embracing the uncomfortable.
Yeah. And it's interesting because I saw that in your story, like, hey, it took me 5 years to get comfortable with this, but I got comfortable with it eventually. And
Mhm.
now you're like a real, I'd call you an expert in ocular surface treatment.
Yeah.
Um, so if people, Cecilia, if people wanted to find you and reach out to you, maybe they want to talk to you about, hey, these hard responders, these Sjogren's patients, how do I deal with them? Or anything else they want to reach out to you about, what can they reach out to you?
So you can find me on social media for sure. My Instagram, Cecelia Koetting. If you want to follow me for random things in my travels, Dr. Jazz Hands on Instagram. You are more than welcome to also just email me, Dr. Cecelia Koetting at gmail.com. Dr. Period Cecelia Koetting at gmail.com. I do my best to respond as quickly as possible. I think we all have over inundated inboxes, but if somebody takes the time to reach out, I am always more than welcome or more than happy to do the best that I can to kind of help navigate what's going on.
Awesome. Well, thank you. And we'll put those in the show notes
Yeah, absolutely.
as well. So if people want to reach out, they'll have that. So thank you again, Dr. Koetting, for being on the show with us today.
Thank you so much for having me.
It was fun. And thank you, audience, for listening. If you learned something today, laughed, or just feel like you need to share something, please share the podcast or the YouTube videos with a friend, colleague, anyone you know. And thank you again, Dr. Koetting. This has been another exciting episode of Optometrists Building Empires. We'll see you next time. That's a wrap on another episode of Optometrists Building Empires. Thanks for joining. For show notes and more, visit buildingempires.live. This show is proudly sponsored by My Business Care Team. My Business Care Team was born out of staffing challenges my wife and I faced together, managing multiple optometry locations. We refined our approach at Classic Vision Care and now offer our expertise to others. If you're experiencing challenges with staffing and you'd like to set up a discovery call, we'd be happy to help you and connect you with the right resources. We'll see you next time.